Hello everyone, I'm Dr. Bishal Gyawali, Associate Professor of Oncology at Queen's University, Kingston, Canada, and I'm very happy to share with you all today about some of the most exciting data that I just saw at the plenary session at ASCO 2025. But before that, I'm going to talk to you about a fantastic new drug called Exercisezumab, and I'm of course joking that exercise has shown to improve lives of patients with colon cancer. And I'm joking that if this was a drug called Exercisezumab, the data are so compelling that we'd all want to use it today. We'd all want to fund it today. But because this is not a drug and it's about exercise, so I see some challenges in implementation, and I hope that I'm able to convince you that the data are really compelling and we should make an effort so that our health systems will integrate this as a part of cancer care for patients with stage 2 high risk and stage 3 colon cancer who receive adjuvant chemotherapy. So the trial I'm talking about is called the Challenge trial. That was not presented at the plenary, but should have been. And in this trial, patients who had high risk stage 2 and stage 3 colon cancer after they completed their adjuvant chemotherapy, they were randomized to receive a structured exercise program versus the standard of care arm. And the standard of care arm patients received health education but did not receive a structured exercise program. And the goal of this structured exercise program was to improve the physical activity by at least 10 MET hours compared to the baseline of these patients. And the findings that we saw, the bottom line baseline findings, the primary endpoint was disease-free survival. Disease-free survival was significantly improved, and overall survival was also significantly improved. So the 5-year DFS rates have improved significantly by almost 7%, and the 8-year overall survival rates have also improved by almost similar amount. And the hazard ratio for DFS is 0.72, the hazard ratio for overall survival is 0.63. These are very, very compelling results. If you compare these results with the results from other trials, you see that this is a no-brainer. And if this was a drug, you would want to use it today. But some of the nuances about this trial that I want to highlight is when we talk about the results of this trial, some of the comments that I got was, oh yes, I have been asking my patients to exercise anyway. Exercise improves quality of life, it will reduce weight, and these are all known to benefit patients. And I have been telling my patients to exercise. But this trial is not about telling patients to exercise. This trial is about having a formal structured exercise program as described in this trial. There are particular details. Patients need to have an in-person visit with the therapist every 2 weeks for the first year, and then every month for the next 2 years. So it's a 3-year therapy program. So it's a scientifically designed and tailored program. It's not just saying, oh, you should exercise. And in fact, saying you should exercise and giving some health education was the control arm of this treatment, not the interventional arm. And a very interesting thing is that because the control arm patients were told about this trial and they were told about the potential benefits of the exercise, and that's why you need to enroll into this trial, and were given these health education materials. An interesting observation is that even the control arm patients had improvement in their physical functioning and VO2 and all those parameters from baseline to subsequent visits. But one limitation is the adherence rate to exercise, and we see that the adherence rate kept falling with time, and I think by the end of 3 years the adherence rate to the exercise program was around 60 to 65%, in that ballpark, which is a limitation. But having said that, the analysis accounts for all of that. Despite that limitation, we are seeing this substantial benefit. And if you want to compare that with the Atomic trial, which was a plenary presentation of using immunotherapy plus FOLFOX for patients who needed adjuvant FOLFOX in stage 3 colon cancer patients, and of course Atezolizumab addition to FOLFOX improved DFS rates. And the primary endpoint here was 3-year DFS, and it improved significantly. And it was a plenary, and people were making an argument that this should immediately change practice. But if you compare that with this exercise trial that I just discussed, A, think about the added toxicities, B, think about the added cost, and C, think about how feasible it is to implement. I think it's a no-brainer that we need to start having health systems fund for a structured exercise program for our patients with colon cancer. Yes, the Atezolizumab data, the atomic trial data looks very interesting, and this is one of the first advances in treatment of adjuvant colon cancer in a long time. This is for patients with MSI high status. But we don't have overall survival results yet. DFS is a much reliable predictor of OS in this particular setting. So I believe that OS might be positive, but we also need to know what percentage of the patients got immunotherapy when they relapsed, because immunotherapy is already standard of care for these people when they relapse. And B, the other point about this trial is, do they all actually need 1 year of atezolizumab? Probably not. And as the discussant highlighted in her talk, in many settings we are now using neoadjuvant strategies, so probably using 2 or 3 cycles might be enough. But the broader point that I'm trying to make is contrasting these 2 studies and to invite you to think about how different these are, even in terms of magnitude of benefit. The exercise trial has overall survival, not just DFS, at 8-year time point. And the cost, when I asked Dr. Booth about the cost of this intervention, he said for the whole 3-year time point, it might be around 3,000 Canadian dollars. This trial was conducted mostly in Canada and Australia, as opposed to atezolizumab, and a month of atezolizumab alone is going to cost 15,000 US dollars. So that's just a perspective that I wanted to put forward. One more thing I wanted to talk about today is the SERENA-6 trial that was discussed at the plenary session. This is a trial for patients with estrogen receptor positive, HER2 negative metastatic breast cancer. For these patients who have been on CDK4/6 inhibitor plus aromatase inhibitor for 6 months, they were then tested with ctDNA to detect ESR1 mutations early, and if this was detected, then they were randomized to either follow the same treatment, which is the control arm, or get the new drug. And the primary endpoint here was PFS, and this was debated a lot during the session. The primary endpoint of PFS in this trial, I think, we have so much debates about PFS and OS, but for this particular trial, PFS makes no sense, because this is just detecting relapse early, and detecting relapse early does not mean always that you need to intervene early. And of course, if you are intervening early, then you are going to prolong disease progression, time to tumor progression. So the PFS in this sense, it's more like time on treatment with this drug rather than true progression-free survival. You are just changing treatment early, and the control arm patients are not getting that treatment when they progress. So measuring PFS alone here, it felt almost similar to measuring CA125 or whatever tumor markers we measure, and then institute treatment early and then claim that patients have a longer time on that treatment, when in fact it's just lead time bias, or intervening early without knowing that it's going to improve outcomes. And a final trial from the plenary session, the Matterhorn trial, I want to bring that up as well, because this trial, Matterhorn trial, was a trial of using Durvalumab plus perioperative FLOT in patients with esophageal cancers. And this trial had a significant improvement in event-free survival, but has not improved overall survival yet. It may or may not translate into overall survival improvement. But the discussant did not discuss the limitations of this trial well, and that's why I wanted to bring that up. Because there are several factors to consider here. There are other trials in similar setting where EFS or DFS have improved, but overall survival has not. So there is no point in getting super excited about this, because it may not translate to overall survival, just like other immunotherapy trials in this space. And the other thing is, we need to make sure what patients are getting at the time of progression or at the time of relapse. Are they getting the right treatment? If they are not getting the right treatment, then even any survival difference can be simply a function of the control arm patients not getting the right treatment at the time of relapse. And if we compare these results with the results of other immunotherapy trials, I don't think the results are any substantially different. Yes, event-free survival improvement is important, but especially in this setting, in this disease, we have seen other trials where DFS or EFS have not necessarily led to OS improvement. So we need to be asking ourselves, can we claim that it is already practice changing without having those results? And I don't think that's the case. Anyways, those are some of my thoughts from this year's plenary session of ASCO 2025. Thank you.